Hypothyroidism. It's one of the most common endocrine issues we run into, but the symptoms, we're talking fatigue, weight gain, they are just so vague. And if you misinterpret the labs, you can easily miss the diagnosis. So, in this explainer, we're going to build a super clear, step-by-step algorithm to help you nail the diagnosis of hypothyroidism every single time.
First, we'll start with the real workhorse, the TSH first approach. Then we'll dive into what the results actually mean, and I'll show you a critical diagnostic trap you absolutely cannot afford to fall into. After that, we'll figure out the underlying cause, and finally, we'll look at the evidence for who really needs to be screened in the first place.
So why do we need a lab-based algorithm so badly? Well, it's because the clinical picture is, frankly, all over the place. I mean, just look at this list. Fatigue, weight gain, constipation. These symptoms could describe half the people in your clinic on any given day, right? This is exactly why we have to rely on objective lab data to cut through all that noise.
All right, let's get into the workhorse of our diagnostic strategy. For more than 95% of your patients, the whole journey is going to start with one single, incredibly powerful test.
And that test is the serum thyroid stimulating hormone, or TSH. Now, TSH is released by the pituitary gland up in the brain, and its whole job is to tell the thyroid gland down in the neck to get to work and produce thyroid hormone. It's an unbelievably sensitive marker for what's going on with the body's overall thyroid status.
So what if that TSH level comes back high? What does that really mean? Well, you can think of it like this. The pituitary is literally screaming at the thyroid gland, demanding more hormone. The brain senses there's a shortage, so it's cranking up the volume to ramp up production. This is our first huge clue.
Okay, so a high TSH confirms there's a problem somewhere in the system. But our job isn't done yet. The very next question is, how is the thyroid gland responding to all that shouting? Is it managing to keep up, or is it starting to fail?
And that brings us to step 2. We repeat the TSH just to make sure that elevation is real and persistent, because sometimes you can get transient bumps from other illnesses. But this time, we also add a serum-free T4. The free T4 tells us what the thyroid gland is actually doing. It's the factory's output. How much active hormone is it making in response to that TSH signal?
This slide really lays out the two key patterns you're going to see. On one hand, if your TSH is high and your free T4 is low, that's it. That's overt primary hypothyroidism. The gland has failed. But on the other hand, if the TSH is high but the free T4 is still hanging on in the normal range, that's subclinical hypothyroidism. It means the gland is struggling and needs all that extra stimulation, but it's just barely managing to keep the hormone levels where they need to be.
So, to be clear, overt primary hypothyroidism is the classic textbook case. The pituitary is yelling, but the thyroid factory is broken and just can't meet the production demand. This is a slam dunk. Treatment with thyroid hormone replacement is absolutely indicated here. I love this seesaw visual because it's such a great way to picture what's happening. In primary failure, the pituitary is pushing down hard, sending the TSH side way up high. But the thyroid is so weak that the T4 side stays stuck on the ground. It's just a crystal clear picture of that peripheral gland failure.
Okay, so you've mastered the primary algorithm. You're feeling good, but now we have to talk about the exception to the rule. The critical clinical trap where trusting the TSH alone will absolutely lead you astray and cause you to miss a really important diagnosis. Just imagine this scenario for a second. A patient comes in with all the textbook symptoms. They're tired, they're cold, they're constipated, and you're thinking, this has to be hypothyroidism. You order a TSH, and it comes back normal. Or maybe even low. So what on earth is going on here?
This right here is the classic presentation for central hypothyroidism. The problem isn't the thyroid gland itself. No, the thyroid is perfectly healthy, ready and willing to work. The problem is upstream, in the command center. The pituitary or the hypothalamus is failing, so it's not sending out the TSH signal to begin with.
And this leads to a really paradoxical lab pattern. You'll see a low free T4, which makes sense for hypothyroidism, but instead of a high TSH, it's either low or, and this is the really tricky part, it's normal. But this isn't a true normal. It's inappropriately normal. A healthy pituitary would be screaming its head off with a T4 this low. That mismatch is your absolute key to sniffing out central hypothyroidism.
This visual shows the core of the problem perfectly. The signal generator up in the brain is broken. The pituitary just can't send the TSH message. And without that stimulus, the healthy thyroid gland doesn't know it's supposed to produce T4. So both the signal and the output are low.
So here's the crucial take-home point. In any patient where you have a high clinical suspicion for hypothyroidism, especially if they have known pituitary disease or other hormone deficiencies, you absolutely cannot rely on TSH alone. You have to measure the free T4. It is the only way you're going to catch central hypothyroidism.
All right, so now that we've locked in a diagnosis of primary hypothyroidism, our next job is to figure out the etiology. In other words, why did the thyroid fail in the first place?
In places where people get enough iodine, the overwhelming cause of primary hypothyroidism is chronic autoimmune thyroiditis, which you probably know as Hashimoto's. Now, a lot of the time we just assume this is the cause, but we can actually confirm it by measuring anti-thyroid peroxide antibodies, or TPO antibodies.
And a positive test is really confirmatory. We're talking over 90% of patients with Hashimoto's will have these elevated TPO antibodies, which tells you there's an autoimmune attack happening on their own thyroid gland.
But always remember to think about the clinical context. Not all hypothyroidism is a lifelong sentence. Conditions like postpartum thyroiditis or subacute thyroiditis cause a lot of inflammation and destruction of the gland. This can lead to a temporary hyperthyroid phase, followed by a hypothyroid phase while the gland recovers. This might not require lifelong therapy.
Okay, let's pivot a little bit. We've talked about diagnosis, but now let's tackle a broader question. Who should we even be testing for hypothyroidism to begin with?
Well, the first thing you need to know is that the major guidelines, like from the U.S. Preventative Services Task Force, do not recommend routine population-wide screening of adults who don't have any symptoms. The evidence just isn't there to show that it actually improves important clinical outcomes. So instead, we use a much more targeted, risk-based approach.
So who are these high-risk folks?
Well, we should have a really low threshold to test women over the age of 60, anyone who has another autoimmune disease like type 1 diabetes, and patients who've had thyroid surgery or radiation to their neck. And of course, you've got to be vigilant with patients on certain meds like lithium or amiodarone, or anyone who shows up with a goiter or unexplained high cholesterol.
So let's end with the ultimate takeaway, the thing to burn into your brain. High TSH plus a low free T4 equals a primary problem in the thyroid. But a low or inappropriately normal TSH with a low free T4, that is the signature of a central problem in the brain. Always consider the central hypothyroidism trap and never ever get caught looking only at the TSH.